Good morning, everybody. And before I start, my thankfulness to the Delhi group, Raju sir, and everyone. It has been an excellent learning for me rather than anything else. So many things that I have got, and it was nice to connect back with Babulkar sir from the days when I was a student with him. Um, and it's an excellent time that I have spent here. So this is the first thing that I should say. And I work at Bangalore, and I deal with a lot of these shoulder issues. And before I start on this itself, another very important change that Dr. Chetan Sood's talk gave to me about this kind of cases, because I have been dealing with glenoid bone defects in primary shoulders, quite a 10-15 cases I have done. So it was probably that I was not aware of certain things which I have become aware of also. And now this lady, a 79-year-old lady, she was a Kalaripayat training, she was excellent in Kalaripayat. Till 77 she used to do that. And at around 77 years of age, she started getting some shoulder pain. Got investigated, had a small tear in the rotator cuff. 6 months to 1 year she just lived with it. Couldn't manage for more than that. Night pain was increasing. She couldn't go back to her sport also. But she was totally disturbed by that. And she came and underwent a surgery somewhere else on the shoulder, and the pain became more. First, initially post-surgery, what was happening was she had some movements and pain had gone. But around 2 months down, post-physiotherapy and all, she had total inability to use the arm itself. And range of movement was only a little bit of jog possible. So I just went ahead and saw what was being done. So it was a rotator cuff tear, 2-year symptom, had a retracted supraspinatus tear with around 50% muscle atrophy, but it was not a cuff arthropathy case. Was able to use arm but was disturbed by the pain. Now post-surgery has become totally unhappy. And this was the presentation I had of the shoulder. Now the central screw had just fallen down. The whole glenosphere seems to have gone upwards. So this all investigations were done somewhere else. So basically got a CT. They had done a CT, assessed that CT. Because of the metals, the images were not too great. Yeah, they have taken off and made a sequence to assess the glenoid also. Glenoid flattened much below the level of the coracoid, but still the clarity levels not. That is the X-ray we have, sir.
So that's the chest X-ray, the one that you've shown us.
Yeah, that is the X-ray we had in the that's the only X-ray available.
But you would have done none, right? Before surgery, I hope so.
Why would you need a true AP X-ray?
Sir, the whole thing was they have decided surgery and they have come to me, and with all possible investigation they have come. So if I speak anything, these are surgeons whom I know. I have to be very sure. So I particularly told, if you are not ready to ask me anything of what has happened, then only I will look forward.
Why are you carrying the baggage for the other surgeon?
No, it's not possible to practice in
forget the past. It is possible. It is all mental. Yeah. I'm saying that from your surgical point of view, you are doing a revision surgery. You need to be whiter than white in terms of a plan. So maybe get couple of investigation extra. The least you can do is a good true AP and a good axial, because the assessment of glenoid vault can be done only on true AP X-ray.
So true AP axial, that is that outlet view, and all the CT scan images were done. It's not done. It is all done. It's available. And what we have is a very flattened and basically a flattened and deep glenoid.
I would expect that.
Which has gone into at below the level of the coracoid.
If you have Adobe Photoshop, then you can just wipe out that previous surgeon's name and still display the.
So we can move forward.
The question level. And this is the question. So whether
So,
single stage reverse with bone graft will be done here, single stage reverse with augmented glenoid prosthesis.
I think we had a poll. Everyone was with a single stage reverse with augmented glenoid prosthesis.
But
So I
do we
think-
have these augmented
You want to
glenoid
poll again?
prosthesis
We
here?
don't have right now augmented glenoid as used to have.
When did you operate this patient?
This is now 7 months. Sir.
So we didn't have it. Last year we had it.
Why taken off? Sir?
Well, the company bailed out.
So we don't have an augment. So let's see 1, 3, 4. Then what is the option? We have a poll again.
1, 3 and 4.
Let's see what Pradeep did, because
Okay, show of hands. Single stage reverse with, we don't have a second option with us. Single stage reverse with bone graft. So I think quite a bit, more than 50%. And option 3, 2 stage. No one. Option 4, just lot of age free is there. So 2 stage bone graft and then hemi replacement. Okay. So we have option 4, just a bone graft. I think.
What does the option 4 mean? Just bone graft?
No, the glenoid to be bone grafted without changing the, that is the humeral cup remains as humeral cup. And just put a bone graft and come out.
Or if it is a platform, then you change.
It's a platform stem only.
It's a platform. You get teaching it.
Yeah, so
so
change that,
even
that's
if
a hemi
Pradeep,
replacement.
even if you do option number 1, that is still the same. We don't want to mess around with
Change
humor unless you
the-
put the humerus south to north.
So we can move forward.
So we went by the same incision deltopectoral approach, and this is what, see, I had not thought ever that I'll be presenting this case and all. I don't have much details of photographs and all, so bear with me, I'll have to tell what happened. It was totally loose, but the glenosphere had the bone attached still, and it has come out. It was initial, so it could be either that the initial, while they put it, they didn't put it right and it had gone upwards itself, but it looked like it had bone there, and bone had in fact integrated to that also. All other things loose.
Humeral side was not loose, right?
Humeral side no, not loose, only the the cup, humeral cup. Yeah, glenoid side, totally, it just came out, there's nothing, with the bone it came out. So I had counseled the patient that I will go in and see whether how much is your remnant of glenoid, and if the glenoid remnant is at least 10 or 15 mm depth, I can find out. Then only I will be proceeding, otherwise I'll be grafting and coming out with doing a hemi replacement. That is what. And the patient 79, she just went away. 6 months later only she came back. She told that, I am not ready for 2-stage surgery, only 1 surgery. But I told, no, it's not possible that I can guarantee you that. I had not met Dr. Chetan Sood till then, so then no, I didn't know that with the implants around, I could do a 3D reconstruction there and could have a better idea before itself. So I went by my instinct, and I just went. I went, and first thing I did after removal was to see the glenoid, how much was the depth. I drilled 1.5 to 2 mm K wires and drill bits and checked the depth, and I found it to be around 13 mm in most places. 13, 14 mm were there. Okay. So
Pradeep, what was your pre-operative planning? Depending on your CT scan, what was the version, how much was the loss, how much medialization of glenoid was there? So did you plan anything?
yeah. So planning में the glenoid side planning is we have by measurement it was around 12 to 14 mm of the glenoid at the place where we could put a peg. Okay, so that is 12 mm and 14 mm and all is not uniform throughout, and the whole thing had broadened and flattened out also. So if we have a 10 mm peg which can go into the native one, we could still go out with primary. So it was almost everywhere 12 to 14 mm. So I was okay, but then because if it is a primary osteoarthritis where it has gone inside, the bone is very strong. Whereas a revision one, when it comes, how the bone will be, I was not very sure also.
Did you check the version of the glenoid?
It was flat, sir. It was flat.
So on the axials it looked anteverted, and on the axials, I may be wrong, but on the axials, not only was it anteverted, it did the most common mistake that surgeons do, where the glenoid base place was in further anteversion. Which means that not only was it medialized, you also had an anteverted glenoid, which means you have to factor in a lateralization plus a wedge-shaped graft, which would cover in anteriorly and make the whole thing neutral.
I think accidentally that was done by the graft shape itself. I didn't plan off in that exact fashion, but I went, measured the size of the glenoid, took a bone graft, almost made it round shaped, tricortical, and
From where did you take the graft?
iliac crest. And because she was a colorified person, her bone quality at 79 was excellent, in fact. And then I put that 4.5 cc screw on the upper part. That's the long screw which is seen as a cc screw to first fix that whole thing there. And once that was done, I made like a standard
In the glenoid, but that is for a central cavitary defect of a glenoid where you want to do revision, previous failed anatomical prosthesis, etc. But what Pradeep has done is a wedge graft, anterior.
yes, it's
anterior
one, it
inferior
is
wedge
broader,
graft.
little anteriorly and
Fix the-
posteriorly thinner.
Yeah.
But that is more accidental, as I told, no, there is, when we see, we know that it was like tilted anterior. So that area, I just made it little more broader.
And the Tom Norris technique is on when you have a prosthesis that has a central screw. This one doesn't have a central screw.
So, Pradeep, the central helical blade was in the native glenoid, or it was at the junction of worn out
No, the
glenoid?
revision one doesn't have this helical blade. The revision one is a peg.
Revision is a long peg, revision is a peg.
So what
Yeah,
size peg
evaluate is
did you
revision
choose?
cup.
What size peg did you choose? There are 3 sizes on
Yes,
that.
sir. So 15, that is 15, 20 and 25. I put around, I think it is 25 if I am not wrong.
That's the one he is speaking about.
Revision, yeah, and it is also the retentive poly also I have changed. I put a retentive poly also on the other side.
Revision glenoid has got an extension superiorly, but you have to cut
No,
it
that I
off.
have cut it.
Cut it off.
That's why I was wondering.
That extension is given only if we could put something that it was obstructing it. So I just cut those things off.
You are allowed to do that.
Now the question is, when I finally finished the whole thing, the question still remains, I think, when we have been discussing, didn't change the stem at all. I accepted whatever version was put, which seemed to be at 0 degree version was that question. How do you select the stem version? These are the 4 questions that I have. It is base it on glenoid, that is just do it anatomical, always 0. For getting, for right side, 30 degree, and for the left side 0 degree, or right side 0 degree. For this is for the theoretical discussion of how much rotations will be there. Which one would you select for the primary? I have not changed. I have put whatever was
Do you have
available
an
there.
ARS?
Pradeep, if you were to do a primary reverse for any other patient, what version would you use?
I always go anatomical, sir. Means whatever is the, when I put the glenosphere there.
No. For the humerus, I am asking you. For the humerus, for a primary cuff tear arthropathy, what humeral version do you choose?
No, once I put the glenosphere there, I go by the anatomical, whatever is available, that anti-version I cut and
ARS
put
is
it.
there, you can vote also.
I don't try putting it customized to right side little different, left side different. Everything facing the glenoid, we just put that. And along the bicipital groove, along the transepicondylar axis, along the forearm, all these points you see, you select and you just put that.
So it's 0 degree, what's everyone say?
But I always find that I put it at,
Sorry,
well, it's
the first
usually
one, the
20 to
base it on
30
glenoid,
degrees
just an anatomical.
retro version.
So the first option, I think everyone has chosen.
Face it towards glenoid and put it.